ecosystem. This is the first Manchester Connected Health ecosystem of this academic year. We typically organize 3 to 4 each year, and as I said, this is the first one. The next one is probably going to be held in February. We're going to focus on digital health inequities today. Just a little bit of background for those of you who are new to the ecosystem or have not joined meetings before. So the Connected Health ecosystem is a community of researchers, health and care providers, people from businesses and the public sector who have an interest in connected health. And our meetings try to bring those people from those diverse sectors together to have a discussion on topics that are relevant to connected health. And as I mentioned today, we're going to focus entirely on digital health inequities, which is, I believe, a really important topic and one that whose importance has again been emphasized through the pandemic. So let me talk you through the event guidance first. I was going to say agenda, but event guidance. So this is meant to be an interactive meeting, so you're very welcome to interact with the speakers. You can use the chat function if you have a question to ask questions to the speakers. You can also raise your hand, and then I will ask you to unmute to ask your question. Please, when you unmute, add your name so we know who you are. And if you tweet about the event, please use the hashtag MCR ecosystem. And please note that we are recording this event for promotional purposes. So the agenda for today looks as follows. We're going to start with a brief talk by Andy Bleeden, who's the chair of the ECH Alliance. That is the network of the global network of ecosystems that our ecosystem belongs to. And he's going to talk about what we can bring in from other ECH Alliance ecosystems. Then we have Louise Levertis, who works at the University of Manchester as a research associate and for the NIHR Applied Research Collaboration, talking about work that she's been doing with a working group that was established earlier this year. Then we have Charlotte Eers-Telling, who works also at the university and for the NIHR Older People and Frailty Policy Research Unit. And she's going to talk about addressing the age-related digital divide. Then we have Laura Rooney from Health Innovation Manchester, and she will talk about Greater Manchester's approach to inclusive digital transformation in health and care. And finally, we have Phil Swan from the Greater Manchester Combined Authority, and he's going to talk about empowering our people through digital. We're going to end with a panel discussion, so that's for the last 20 minutes today. There's also going to be opportunity after each talk to ask a brief question to the speakers, but obviously if you have a question, you can also keep that for the panel discussion, because I will invite you to ask questions to the panel, which will include all the speakers from today. So with that, I am going to hand over immediately to Andy. So Andy, many thanks for joining, and the floor is yours.
Thank you for that, Niels, and welcome to colleagues here at this exciting ecosystem in Manchester. I've been a long time attendee at the ecosystems here in Manchester, going back to when we first started. So it's always nice to see familiar faces and new faces. We're targeting a topic today around health inequalities and health inequities that's been featured many times within the work for both the Greater Manchester ecosystem, but also the rest of our European Connected Health Alliance ecosystem network, and now our global health network. And I'll come on to those in a moment. But I always, when I talk about this topic, I always like to and people will be not surprised to hear this, always like to talk about the need around this and what does that mean. And because of the different language we use, and because as you'll see from different ecosystems, different terminology, we need to be very clear what this means. Not in terms of defining it and giving it an academic basis, but I always think a practical basis. Health inequities and inequalities meant for the work I used to do in regeneration work across Greater Manchester, a very simple fact, and that was death. Death came to people sometimes 12 years earlier in one side of the city than it did to another, because of where they lived and the inequalities that they lived with. That was the same in Manchester, in Scotland, in London, in Bristol, all the places that I've worked with. And what that meant was, in programs not just 2 or 3 years ago, but 15, 20 years ago, addressing those elements that led to lower levels of good health across the age range, that targeted asthma in children, that targeted heart disease in areas that hadn't been approached before. So that's what it means for me as a practitioner in health. That's quite a stark opener, but I think it gets across in ways that sometimes charts don't, and different diagnostics don't really help. Practically in areas just down the road in Manchester, in Stockport, that meant you could see visible differences, health disparities on street level, ward level, lower super output area levels that we could then map and watch, where you have the most richest people living alongside the poorest people in one area, and the differences in health and life expectancy were stark. So that's a grounding for this. I want to talk about the work we do within the European Connected Health Alliance that is both forward-looking but also cross-border on this, because many of you who've been involved with these ecosystems before usually sort of think, oh, what is Andy rattling on about? Need to think about outside of Greater Manchester, because there is a world outside of Greater Manchester. And that topic's the same for today. But I'm going to give you some positive examples of where we can perhaps in Greater Manchester connect up with the rest of our ecosystem network. I've only got a couple of slides because I think for a Monday morning, we're probably going to get a great big pile of slides thrown at us, and I think that's rather mean after a long weekend. So I want to try and keep this short because I want to get the conversation going between us. But just a little bit about us. My role here is as a director within the community side of the European Connected Health Alliance. I talk about the words community because we are a very, very large community, global network with about 900 members, organisations, many of whom are here today. And we bring those people, those experts together in ecosystems, just like this one. And they're mostly not-for-profits, patient groups, hospitals, government bodies, etc. Some companies too. And we use our ecosystem network to bring them together on challenge related topics, whether it be mental health or diabetes or falls prevention, or on this one around health inequities. Because we see the benefits for bringing people together, all the stakeholders in health. Many of you have seen this before, including patients, including companies, also including policymakers, and yes, academics and funders. I always want to know with each ecosystem is where the need is at the beginning, and I always think that's best dealt with by bringing examples from family groups, citizens groups, patient groups, to see the lived experience around digital health. We use our ecosystems, and Manchester was the first one, set up over 10 years ago now, to match need and solution, bringing together and leading with a need, but breaking down some of those silos that around health inequities mean understanding the processes we have as health providers welfare providers that actually make people worse, not better. That where some of the interventions we do prevent people from accessing healthcare. We also try to encourage people to transform healthcare, and today we should be looking at some examples of that, where we bring practical methodologies together to seek to tackle health inequalities where they exist. But also, and this is always the case with no matter what ecosystem we talk about, to look at the actual economic opportunities that could be there for businesses, because this should be an area that benefits the economy. And I think Manchester get that because of the involvement of the combined authority in this area. Our network's grown, and many of you have seen that grow and have taken part in some of those other ecosystems we have. We've just opened our 70th ecosystem in Japan and Moldova, but we're also seeing growth outside of Europe that we didn't experience before. We've got ecosystems in Australia and Argentina and Brazil, and we had a coordinators call the other day which brought those ecosystems together so we could hear from what they're doing in Chile as well as Canada. Each one of those ecosystems I know have an interest in this topic around health inequalities. You might call it something different, but the interest is still there. What we've sought to do during the pandemic is work with our networks of these ecosystems, these 70 ecosystems now, to bring together and create what we've called thematic innovation ecosystems. And here's the offer for Greater Manchester. Because to do this on our own in Greater Manchester would be an opportunity wasted. But to work together across the UK or across Europe or indeed across the globe in areas that we know where there's lessons to be learned and shared is a great opportunity. That's part of being in that network with the European Connected Health Alliance. Because I know practically that within Australia or within Sri Lanka or within Africa, where we're building our new network of ecosystems this year, there's some great learning for Manchester, but also great opportunities to share your best practice. What that means in practice is that we've looked to create a series of these thematic innovation ecosystems, which are led by our actual ecosystems that we've got, where we can bring together the best of what we know our ecosystems can do. So we've established these thematic ecosystems around the field of mental health, or around health procurement, or aging and housing and health. And there's an event later this month led by our Italian ecosystem, which I'd invite you to, and I'll put a link in the chat later, around housing and health. Because again, housing has an impact on health. We know that, and those people who worked in housing will well understand the implications around health of poor housing. What we've also done is to create a brand new thematic innovation ecosystem with our new global partners, the American Telemed Association. So we're looking to partner with them to create a specific ecosystem that targets the area of health inequalities and the social determinants of health. In America, they're very, very much interested in this topic for exactly the same reasons we are in the UK. And I think there's many opportunities for us to learn and share what we're doing here with colleagues in America. Yes, there's differences in terms of healthcare provision. Yes, there's differences in politics. And yes, there's differences in terminology. But they are just words. The area that they're targeting is still going to be looking at the areas we target today around accessibility and affordability and connectivity, etc. They're exactly the same, but just on a different level, on a different scale. And I know that's exactly the same in Germany, or indeed in Finland, where those same elements are talked about and shared. So we're going to create a brand new thematic innovation ecosystem purely on the social determinants of health. That will bring together, again, all of those stakeholders, but on a global setting, to bring need and solution across from different countries.
Hi, Andy. Just keeping an eye on the clock here. Could you round off imminently?
Yeah, I'm finishing
Thanks.
now. We will use this to bring best practice, hopefully from Manchester, to that global stage, and also vice versa. So I'll put the link in the chat function. Get involved. Stay alert to the opportunities that are coming through today, and I look forward to speaking to you. Thank you very much.
Thanks very much, Andy, for that overview. Really exciting to see what's happening in the other ecosystems. Any quick questions for Andy before we move on? If you have a question, please enter it into chat or raise your hand. Ruth.
Thanks, Niels. Hi, Andy. I just wondered where you think you might be going next for the next ecosystems. Are you there, Andy? He's obviously gone to get them immediately. So
I think so. Have we
I think he's left. Yeah.
Yeah.
Just left.
Okay. What I suggest is that we move on now and we keep that question for the panel discussion later on, if that's okay, Ruth.
Great, thank you.
Sorry about that. I got kicked out. Pressed the wrong button. I'll come back to that later, Ruth. Sorry, and I'll give you some examples if later if that works, or I can answer now. It's up to you.
Yeah, I think, Andy, let's pick it up in the panel discussion.
Yeah.
Yeah. All right. Thanks. Okay, so we're going to move on immediately to the next talk, which will be given by Louise Levertis. So Louise is a sociologist by background, and she works for the NIHR Applied Research Collaboration Greater Manchester, the ARC, in my team, in the digital health team, where she evaluates a number of different digital interventions, but she's also worked together with Sabine van der Veer on setting up a working group on digital health inequalities during the last months, and that's what she's going to talk about today. So, Louise, thanks for joining, and the floor is yours.
Thanks, Niels. So thank you for the introduction as well. It saves me a minute or two from the talk. So today I'm just going to be talking about the development and directions for the Digital Health Inequalities Working Group that was set up with the NHR ARC Greater Manchester and in collaboration with the Christabel Pankhurst Institute as well. And so just giving you some background into the kind of perspectives we're taking and where we're going next. So just to give a brief overview of the different types of inequalities that we're looking at. So we all mainly know about the idea about digital access, so people's access to technology and people's access to the internet. Inequalities around digital literacy, so people's capacity and motivation to use technology for health purposes, also known as e-health literacy, as well as underlying levels of health literacy as well. We've also got this idea about digital inclusion and exclusion, so users of the same service will use it in different ways, stop using it or choose not to use it in the first place, and inequalities in terms of the reproduction of bias and discrimination in some digital health technologies as well. And so the group is really taking this idea that we need a range of perspectives. So for example, Honeyman did a recent review about digital technologies and health inequalities, and they found no evidence to help us understand the question of whether the use of technologies is widening or closing the health outcome gaps between groups. But there is an abundance of literature on the role of digital health technologies to draw on from other disciplines that might not have been picked up by that review. So in the social sciences, in cultural and media studies even, and in implementation science as well. And these kind of perspectives take this idea that technology is not just an object and technology is not just a tool. Because when we think of technology as just a tool, it separates technology from the way that it's embedded in relationships and health systems, And it treats technology as necessarily neutral and objective and inevitable that it works one way for everyone. And it also positions technology as cold in comparison to warm human caring work, which isn't helpful either. So instead, they suggest we take technology as a process to understand that social, political, and economic forces shape the way that technology is funded and designed and adopted. We need to understand what technology and people do together, that technologies have a limit on what they can do by themselves. They have to be enacted by people. So really to focus on how and why technologies result in particular outcomes. So when we think about inequalities in the development of technology, there's a lot of literature around how the gendering of technology and engineering really excludes girls from a young age. And we know that the big global technology giants are predominantly controlled and made by white men in their 30s and 40s. Where digital health technologies are often designed by clinicians and often are designed from international and national priorities rather than patient needs. And we know that politicians are very keen to see the potential for digital health technologies to help reduce health inequalities, but there are some gaps. So we know that when we look at digital health policy in the UK, there's quite a narrow framing of what inequalities are. So they often focus on digital access, for example. And they don't always consider the wider forces that impede engagement with digital health. There's also this idea that often problems are turned into problems of technology, because when we reframe problems into one of technology, they're seen as something more manageable. So for example, within the NHS, it's easier to say we're going to fund a big technology project than to fund staff and resources, for example. It's a lot more tangible. And often the development of digital health technologies outpace the creation of ethical and legal frameworks. And just this idea that things are being rolled out without necessarily evidence behind them to suggest they are going to have a benefit, and also not considering unintended consequences. Also, in the development of digital health technologies, there's this idea that we may reproduce bias and health disparities through the people building them or the data used. So if we use classifications and predictions based on historical data, it can mean that past ways of thinking will shape present actions. So most of the research is around inequalities in the adoption of digital health. So we know from kind of reviews that there's a few key themes to think about. Firstly is this idea about re-spatialization. So when we move care outside of the hospital and outside of the clinic, it can change the meaning and experience of the home for people. It can make illness more present in their home. It can change domestic spaces with equipment and assume that patients are homebound and able to input data when needed. It also means that care is also reconfigured. So who does the work and the nature of tasks. So when we introduce new technologies, we're often giving patients new tasks, such as new clinical tasks to monitor themselves and new data to collect, and for clinicians as well to interpret new forms of data. And we know often that it's about redistribution of work rather than a reduction of work. So there's not a direct relationship between technology efficiency and working time. And again, this idea of what is prioritized. So we know technologies from industry are more likely to be adopted into research and clinical practice. And we know that only some groups will participate in evaluation studies as well. So I was also asked to kind of think about the practical things to consider that we're taking from this literature. So we've kind of got a list of questions for people to think about when they are developing and implementing and adopting digital health technologies along the way. And the kind of maybe key point at the bottom is that Zeblin has said we need to think about developing dark logic models. So when we're considering the intended benefits of interventions through logic models, we should also systematically consider what the consequences might be. And so to our group, so there's a digital health inequalities working group set up over the past year, led by Sabine van der Veer. And it's really about establishing a community of researchers and stakeholders within Greater Manchester to provide advice and support to help understand, identify and address digital health inequalities. We're hoping to develop a sort of theoretical framework to understand it, and also develop methods for identifying and addressing these inequalities at different stages along the translational pathway. We're also hoping to develop a sort of mid-term plan to develop a programme of work around this topic as well. So far we've held 3 workshops over the summer of 2021. The first workshop was about identifying community needs and a long list of interests. The second workshop was about prioritising community needs. And the third is about developing working group plans for the future. So just to focus in on workshop 2, when we really tried to prioritise what people were interested in, the first was about how do we define and measure digital health inequalities. And the kind of group thought about this idea about having maybe a consensus meeting or a scoping review. And the second question is, how do digital technologies impact on health inequalities? Understanding what are the mechanisms through maybe a realist review, gathering some case studies and creating some dialogue around it. And the third was about how do we design studies and technologies to minimise the risks of this. So, and again, this idea we need to be looking at collaborating with other groups to share expertise. And in workshop 3, we asked people to think about what they wanted over the next 6 to 12 months. The most popular was about attending seminar series. So there's obviously interest in learning more about the topic. People are also interested in contributing to research and funding, but also about public engagement and knowledge exchange as well. And so for the next steps, what we're really interested in doing is establishing a working group properly, to establish a community of people interested in this topic who want to work together. We plan to organise a seminar series for next year and to start working on other bits and pieces to collect best practice, start doing some reviews and create links with other partners. So just a quick information saying, if you want to know more or interested in being involved in any way as speakers, part of the working group, please do get in touch with Sabine and myself. So I think that's me. Sorry for powering through.
Great, thanks, Louise. Fantastic, I think, that we have this working group now at the university. As you mentioned, this is going to be a joint venture between the Applied Research Collaboration, the ARC, and the Christabel Pankhurst Institute. And I think it was also great to see the level of engagement in those meetings, the workshops. I think at one of them we had 50 people, and I think that's fantastic to see that so many people are engaged with this topic, and it also provides evidence that we have critical mass in Manchester to work on it, which is good. Any questions or comments for Louise before we move on? I actually had one question myself, which is, Louise, looking at that agenda that you showed us towards the end of your presentation, basically, if you want to do that thoroughly, you have to then look at those 4 different types of inequalities that can emerge through digital technologies, isn't it? So digital access, digital literacy, digital inclusion, exclusion, reproduction of bias and discrimination. So it is very comprehensive, isn't it?
Yes, so I think any sort of review we do, we'll need to kind of break those down to the different parts, because they are all connected and they all link together. But there's also, different interests and different levels of information for each of those inequalities as well. So we know there's a lot of interest in this idea about bias and discrimination in the building technologies. And we also know that there's a lot of government priorities around digital access. So it's about how we bring them all together that hopefully the working group will be working on over the next year. Yeah,
I have an interest myself in especially the topic of reproducing the potential reproduction of systemic biases and discrimination when you use AI, which is something that only emerged, I think, 3-4 years ago. I think it was that the AI community became aware that that is a possibility, and that AI models can easily do that without us being aware of it happening. And there are some quite frightening examples, actually. One involves Google Pictures, and yeah, the same thing is clearly possibility in health, but we're only starting to understand how that really works and whether we can actually avoid it, which is a kind of an open question at the moment, I think.
Yes, definitely. And there's lots of very interesting work, I think, in the States around this, and really pointed to the need that we need to not see AIs as black box, that in order to kind of tackle these, we need to be thinking about the different ways we can audit AI to be able to kind of identify them, but it is a challenge.
Thanks, Louise. So we'll see you back at the panel discussion later in the meeting. So we're going to move on to our next talk, which will be provided by Charlotte Eos-Telling. So Charlotte is also a research associate at the University of Manchester, and she works for the NIHR Older People and Frailty Policy Research Unit. She very kindly stepped in for Professor Chris Todd, who was originally announced to be here today, but unfortunately couldn't make it. So Charlotte, many thanks for stepping in, and looking forward to your talk. The floor is yours.
Can you see that as a slideshow or not?
Now we do, yes.
Yes, brilliant. All right, thank you very much, Niles. So as Niles said, I'm Charlotte Eos-Telling, and I'm a research associate with the Healthy Ageing Research Group at the University of Manchester. I'm working specifically in the Older People and Frailty Policy Research Unit. So I'm going to give you a brief overview of the work our group is doing on addressing age-related digital divide before talking a little bit more specifically about a project we're currently undertaking. So the Healthy Ageing Research Group is a multidisciplinary group of researchers across the university with strong links to the Older People's Frailty Policy Research Unit and the Healthy Ageing theme of the applied research collaboration. So within both these groups, health inequalities, digital exclusion, and the impact of digitalisation on older people are very important areas and key research themes. So the Policy Research Unit undertakes research to inform policy and decision makers, and this falls into two broad categories. Firstly, we undertake evidence reviews, so gathering the findings from existing research to advise policy. And secondly, we have a responsive mode where we answer urgent questions from the Department of Health and Social Care, and we provide briefing papers and research for those answers to those questions. The Healthy Ageing Research theme is part of the bigger ARC group at the university and focuses on evidence-based research to promote healthy ageing across Greater Manchester. So in terms of, give you an idea of just some of the work we've done previously, this is an evidence synthesis which we've just completed in the Policy Research Unit on the effect of digitalisation on older people's access to health and social care. And as Louise mentioned earlier, this review also found that there's been no unclear, so the evidence is unclear on the equitable access to services for older people. So we're suggesting that research is urgently needed in order to understand the positive and negative consequences of digital technology on healthcare access and to identify which groups are most vulnerable to exclusion. So following on from this piece of work, we're starting a new evidence synthesis in the new year to understand the impact COVID has had on the digitalisation of health and care services for older people. And so which services have been digitalised and what are the barriers and enablers to accessing those services? In terms of so in terms of a piece that was undertaken as a rapid response, this was one that was undertaken in the COVID pandemic, and it came about because during the first lockdown there was a concern that stay-at-home measures to reduce transmission of the virus were having an adverse effect on older people's levels of physical activity, and that can result in deconditioning and an increased falls risk. So we presented a briefing to the DHSC on the potential use of digital technologies to increase physical activity during COVID-19, and that was based predominantly on two pieces of work that were underway at the time. So if I turn to the ARC group, there's been a focus recently on the development of new platforms and apps to support older people managing their health. I'm not going to go into detail today about each of these, but just to mention a few of them that are currently being evaluated or are near ready. The first one is the Keep On Keep Up, or COCU app, which is and platform, which is working with strategic partners to develop a program to deliver personalised exercise plans, which build engagement and adherence to maintaining physical activity. The second one is Standing Taller, which is another app that's being developed to improve balance and reduce falls, and includes behavioural techniques to enhance exercise uptake. And then the third one falls within the HARC group, but just outside the PRU and the ARC group, is called Motivate Me. And it's a dual app that's been, two apps, sorry, that have been developed in tandem. One is for the health professional and one is for the patient with a home exercise programme. And that's currently being evaluated as well. So I wanted to move on to talk a bit about another piece of work we're actually undertaking at the moment within the ARC ageing theme. So it's a smaller piece of work that's building on evidence reviews undertaken around digital inclusion in the policy research unit during the pandemic, and also work carried out by the ARC Healthy Ageing theme last summer around keeping well at home. So this work's exploring factors that have impacted on older adults, that's those who are 75 plus years, on their access and experience of public services during the COVID-19 pandemic, with specific reference to digital inclusion and exclusion. So the first phase of this work was a rapid review of the current evidence around older adults' digital skills, their internet use, non-use and disengagement. So how many older people were accessing the internet, what were they using it for or not using it for, and also looking at evidence around whether they'd engaged or disengaged from using the internet during the pandemic. Also, what kind of support was needed to help people get online if they weren't already. So we've just completed this review and it will shortly be circulated to our stakeholders. Within the review, we spotlighted a number of key areas and highlighted the specific findings in those areas of society. And I'll talk about each of those in turn in a minute. What are the pieces of the key jigsaw pieces to bolster digital inclusion? Well, I think we've talked a little bit about them before, but it's about ensuring that we have the right services and tools in place for people to get online. Also ensuring people have up-to-date skills and the right skills to use the technology once they have it. And support is key, especially for older people. So it's support which is task-based rather than skills or technology-focused. So in other words, it should concentrate on helping people do the things they want to do with the technology rather than focus on the technology itself. And to avoid technological jargon as well, technical jargon, sorry, because that's a real turn-off for older people. Peer mentoring here can be really important and it's very effective for helping people to get online. And finally, ensuring people have confidence in their skills and confidence in knowing where to start to get on the internet, and also motivation. So people need to see how the internet is going to be beneficial to them in order to want to get online. So the other side of the coin, what are the barriers to inclusion? Well, some of them are the flip side of the other of inclusion, of getting online, but lack of skills is really key. Being unaware of the benefits and risks of being online. So that can include also being fearful of online crime. And a lot of older people are afraid of online crime, whether it's true or not, that's a big barrier. Employment history is quite key as well. A lot of people, for some people, retirement is a trigger to stop using the internet. So maybe it's something they've associated with their working life. And now they've retired, they don't want to go back and use the internet anymore. Some people feeling like the internet and digital technology is just too hard for them to want to go there. And families are really important here because family can be really encouraging to get people online, but they can also be a barrier, especially if they think that person is at risk of being scammed or have online crime again. Again, as I said, if people don't see the relevance of being online, they're not going to take up that opportunity. And then poor access and high costs can also be a deterrent. In 2021, the Lloyds Bank Essential Digital Skills Report outlined a hierarchical framework of digital skills essential to access the online world, as well as those deemed necessary for life and work. The foundation level here in the middle consists of 7 foundation tasks, including connecting a device to the Wi-Fi network, opening an internet browser, logging into accounts and changing passwords. And a person can be considered digitally excluded if they can't do any of those 7 tasks independently. At the next level up is EDS for life, and that's 29 tasks split across 5 domains: communicating, transacting, problem solving, handling information, and being safe and legal online. In the UK, just under 3 million people are considered digitally excluded. Around 10 million don't have the full set of foundation level skills, and around 11 million lack EDS for life. Most of these people are older adults. Only half of people aged 65 and over have foundation level skills, although since last year, another 1.5 million have been added to that and are now able to do some of the basic skills, meaning there are fewer older adults who are completely digitally excluded. But a similar proportion of people aged 65 and over have EDS skills. However, looking at the age 75 and over, there's a substantial drop-off, and around 3/4 of people aged 75 plus lack either foundation skills or EDS for life skills. So if we look at what's happened to internet use over the last few years for older people, the latest data from the ONS statistics shows that the internet use has increased substantially across all older age groups in recent years between 2013 and 2020. However, despite this progress, nearly half of the people aged 75 and over haven't used the internet within the last 3 months, and over a third have never used it. So what we're finding is that the COVID pandemic has had a substantial increase in online provision and delivery of everyday services and activities. Overall, however, it doesn't seem to have led to substantially higher numbers of older people getting online, as increased use has come largely from those already using the internet. Age UK analysis of the English longitudinal study of ageing, a COVID sub-study conducted early in the pandemic, showed that 45% of 52 to 64-year-olds and 41% of 64 to 74-year-olds, used the internet more since the outbreak. But only 24% of those aged 75 plus increased their usage, and 9% were actually using it less. So turning to the spotlights that I mentioned in the report, the first of these is access to health and social care. We know that access to health and social care, digital exclusion directly affects access to health and social care, but it also has knock-on impacts for wider determinants of health, including social participation. So, for example, if you are unable to access your medicine for your condition, you may not feel up to socialising with other people, and therefore you're also losing those connections. Old age is the single strongest indicator of internet use or lack of internet use, and those in lower socioeconomic groups where there may be more deprivation are also less likely to use the internet, with Ofcom showing that there were 4 times more likely to be excluded. So the people who are most likely to be excluded from health and care services are also those who are most likely to have the greatest need. People with disabilities can also struggle to access digital services. For instance, sensory impairments such as sight or hearing loss can make access to video consultations more difficult. And although it may be possible to get adaptations or assistive technology to help, these can be costly. So our reviews on the effects of digital technology on older people's access to health and social care found no clear evidence for whether digital technology helps older people make first contact with services, or that technology improves their ongoing access to services. And that really doesn't fit well with the NHS's Empower the Person roadmap, which focuses on the use of digital technology to enable people to better manage their own health and well-being. And the only thing to say is that this work was carried out before the pandemic. And as I mentioned earlier, we're doing more work to look at this in what happened during the pandemic. So notwithstanding that, it's a complex area with nuances. So, for example, in rural areas, people may lack broadband to be able to have effective online consultations, but they may actually prefer those remote consultations to cut journey times. Turning to financial services, these have seen a substantial increase in digital delivery, particularly over the last 15 years, with smartphones becoming more readily available and affordable. According to figures from Statista, between 2007 and 2020, use of online banking rose from 30% to 76% of the general population, and that's likely to have risen even more in the pandemic. However, this increase has been mirrored by a sharp decline in the high street presence of banks, building societies and post offices. In 1990, there were 40,000 branches available locally, but by 2020, this provision had halved. Now, we know these closures are most likely to have the biggest impact on the oldest old. A report by the House of Lords Select Committee on Financial Exclusion in 2017 found that 93% of people over the age of 80 do not use internet banking. The rapid increase in contactless payment and the near disappearance of cash in society, hastened even further by the pandemic, has caused concern. Recent government consultations on access to cash show a welcome commitment from the financial sector to maintaining access to cash. But the key thing is that much of this access is expected to be provided by ensuring the availability of cash machines. But we know the evidence submitted to the House of Lords showed that a third of people over the age of 80 never use or prefer to avoid using cash machines. So this highlights the need to maintain not just access to cash, but access to cash in a range of ways that suit everybody.
Just looking at the clock, Charlotte, are you ready to round off?
Yeah, I can finish. So I think the key thing to say really is that we looked at public services, which were also really difficult to access. And even where there were opportunities for accessing these, so a lot of claims had to be made online, but where there were opportunities to access them offline, that's also included needing to download and print out forms. So effectively, that's useless. So we know that's been made worse by the closure of public libraries, community centres and cafes. So free access to the internet is more limited, and help from family has been more limited. So yeah, just to say that we're in the second stage of this, we're now doing interviews with older people and community leaders. And I'm going to leave it there, but if anyone wants any more information about any of the work I've been talking about, please use our internet pages. They've got lots more information and lots more to tell you. So thank you very much.
Thanks, Charlotte. Thanks for that overview. Really interesting work, I think, and some important warnings there, I think, as well. Before we move on, any quick questions or comments for Charlotte?
Charlotte, I might just ask a quick question. It's just around, you highlighted some of the kind of traditional barriers to access, and including skills and so on. And one of them is invariably going to be the cash, the money required. And I just wondered, you know, all of us, I assume, are involved, particularly in my research, it involves technology as well, and that's a concern for me. How do we overcome cash as a barrier, do you see?
Well, I know that obviously there are lots of initiatives to try and get people online and to try and support them. And one of the ideas was that there would actually be a dedicated payment for people who are lower income to be used for digital access. And that's something that might come about. It would be welcome, but I don't know. I think it's definitely something that needs to be considered, but the more we move online, the more essential it is to fund that, isn't it? So yeah, I think you're right. It's a key area.
We're getting that impression from patients as well. They don't want to have to pay for a service that essentially, you know, they could get for free if they came to the clinic, for example. And I understand that. Yeah, thank you.
Yeah. Okay.
Right, thanks again. Anthony, I've seen your question in the chat, but I suggest, considering the time, we move on now. But let's keep that question perhaps on the agenda for the panel discussion later on. So Charlotte is going to join the panel that we have towards the end of the meeting. So our next speaker is Laura Rooney. So Laura is Director of Corporate Affairs and Strategy at Health Innovation Manchester. Thanks so much for joining today, Laura.
Yes.
And Laura's going to talk about GM's approach to inclusive digital transformation in health and care. So the floor is yours.
Thank you. Okay, yes, thanks, Niels. So I guess this is quite a good opportunity to build on the previous two presentations, because some of what we're trying to do is put some of those findings into practice. You know, what are we going to do about some of the challenges that have been described? Just very briefly, for those who aren't familiar, Health Innovation Manchester is an organisation that's been formed, we're kind of 4 years old now, to harness the transformative power of industry, the health and care system and academia to accelerate innovation and improvement in health outcomes, reduction in inequalities, and aligning our work to meet the needs of GM citizens. So we have partnerships with all 4 universities in Greater Manchester, as well as the health and care NHS providers, primary care, working across the system with commissioners, and will be a key sort of delivery partner as the kind of GM integrated care system forms. So our role is to take a lot of this insight, knowledge, research, and try to figure out how we put that into practice within the GM system. So I think, again, the previous speakers have really articulated, you know, why inclusion is important. And I know people on this call today, you know, will have a good understanding of that. But, you know, the fact is we move into more of an increasingly digital world. People are at risk of having worse access to services, poorer health outcomes and inequalities. And in terms of strategic drivers, the NHS long-term plan has made a commitment to reducing inequalities and addressing unwanted variation in care, which applies to digital services. And the government digital inclusion strategy is also worth a read. And that simply puts, inclusion is about making sure that people have the capabilities they need to be able to use the internet, access online services, to do things that benefit them day to day. And I think that's quite a nice, simple description. And I think as again has already been highlighted, there is a very clear link between people who are at risk or facing digital exclusion and generally have poorer health. And these people are likely to be older, have poorer health outcomes, have lower income, low levels of education and poor housing. So for a place like Greater Manchester, where we've got high levels of deprivation and vulnerable communities throughout our ecosystem, it's really important that we look at how to address digital inclusion. You know, the foundation of devolution for health and care, you know, 5 years ago was built on addressing digital inequalities, addressing inequalities. And that is about, as much as you know, in order to have good health, you need to have good wealth and good housing and good access to education and support. So it's all very interlinked with the GM strategy and approach for how to tackle inequalities in our communities. I think Phil Swan will talk about this in more detail, but briefly, recognising the importance of what we've just said about inclusion and the impact that that has on our citizens in GM. Andy Burnham has launched a digital inclusion action network, cross-sectoral, private sector, public services, health and care, with the focus to get all under 25s, over 75s and people with disabilities online across GM. And the statistics are quite stark when you consider, you know, we've got a 2.3 million population in Greater Manchester. And, you know, it could be that as many as 1.2 million of those are facing inclusion in digital exclusion in some way. So it's a very, very big, real problem. And I think part of what we're trying to do here at Health Innovation Manchester with our partners is figure out what to do about that. So what we're trying to be, we've been looking at inclusion from the perspective of not treating it as a separate thing we need to do something about, but how do we build inclusion factors into our work right from the outset? And from a digital perspective, that's how we design, deliver and deploy digital services to support health outcomes. And I really like, we had a patient group a little while ago who we were talking to about this, and they kind of said nobody's hard to reach, we have just poorly designed approaches. I think it's just a really useful soundbite to think about how we design digitally inclusive services. And we've been engaged with a company called Habitat, who are based in Leeds. They focus on digital inclusion and this concept of inclusive digital transformation. And this is about understanding the problems and trying to get upstream to address them collectively across the system, having a shared strategy, but based on a deep understanding of community needs, securing collective leadership across the system. You know, we need the leaders and the decision makers across Greater Manchester to understand the complexity and importance of this agenda and get behind it. And, you know, we kind of mentioned money just on the previous conversation, and, you know, this isn't going to kind of solve itself for free. So there does need to be a degree of figuring out how we fund and resource tackling digital inclusion. Building co-production and co-design much more meaningfully into the work that we do, and working directly with people who are most at risk, and then recognising from a health and care perspective that there's only a certain amount that we can do, but there are wider factors at play that are out with our gift and control, such as access to the right infrastructure, tools, access to 3G, and so on. So we're working with the GMCA and wider partners, as Phil will go into in more detail, to try to understand how we collectively respond to this really gritty problem. At Health Innovation Manchester, we've developed a digital transformation method and approach, which is simply put on these slides. So this is how we work with, you know, researchers and our partners like the ARC at the discovery end, to understand these needs and problems more, and then we'll work in a sort of development stage of understanding citizen need, really clearly defining the problems that we're trying to solve, and co-design solutions. And that stage is really important. This is where we need to do some of that in-depth work with our communities and the people directly affected. And then we'll work with our health and care partners and others to deploy that into the system. And it might be that we partner with the ARC to do an implementation science study, or so we're really trying to factor inclusion into this process. So that when we do design and develop digital services, we understand how they may or may not impact particular communities. And this just illustrates there are many factors to consider from an inclusive digital transformation approach, from harnessing research and data through to what that means from an equality and accessibility perspective, how we go from co-design into more user experience design, learning from industry, and ultimately, if you harness all this together, that would lead into a social innovation where we empower communities to be able to implement some of these changes themselves, and that, you know, there's a lot to unpack under all of that. Of course, I'm just skipping through today. So GM Health and Care System has made a commitment to tackling digital inclusion, and we work as part of the Mayor's Digital Inclusion Action Network. And some things we're looking at different levels across the ecosystem are developing a digital inclusion strategy and this evidence-based method, as I've discussed. The integrated care system will be kind of formally legal standing from April next year. So we want to build inclusion into the design principles and understand what resources, skills, expertise are needed to deliver improvements. Developing inclusion insight banks to support shared learning and best practice across the city regions. Some excellent examples of where localities have done some really deep work in digital inclusion. And ultimately, we want to get on and deliver. So we've got a suite of projects where we're factoring inclusion in, where we can test and trial our method and approach. We also need to figure out how we partner with the voluntary sector and the tech industry who've got particular skills and assets in this area. And we're also exploring the links between the inclusion workstream and social prescribing, which is quite active across Greater Manchester. And what does that mean? And just a brief example of sort of how we're trying to consider inclusion in action is in digital primary care. So there's a big project going on at the moment across all 10 areas of Greater Manchester, where we're trying to develop a digital blueprint for primary care, namely GP services. And we've had a huge public insight and accessibility testing phase of the different tools and products that are out there. So we're in the phase 2 at the moment, and we'll need to co-create and test our assumptions and hypotheses with patients, and that's a really interesting piece of work. And some of the early insights that we've had so far is there are lots of benefits to digital first primary care services and GP services, but there are things that really need to be looked at and considered. And we're not saying digital will address all of these issues, but we need to be cognizant about the decisions that we make and understand how these will have a negative impact on some communities and what the alternatives are for them in order to be able to access these services, because we need to have equal access for all people, especially into something as important as GP services. So I'll just leave it there, and happy to take any questions or follow up in the panel. Thank you.
Fantastic. Thanks very much, Laura. Any questions, quick comments for Laura before we move on? I had one quick one myself, Laura, actually. So it was interesting that you mentioned primary care, because from conversations with general practitioners during the pandemic, I picked up that some of them said that the interesting phenomenon that they saw is that with the move to virtual care services, there were also groups, especially younger people, who were more inclined to engage with primary care than they were before. So that almost seems to point towards a form of exclusion that used to exist, which was kind of resolved by the move to digital. And I think it's interesting to realize that, the existing system, if we forget about digital services for a second, the existing system obviously has all kinds of biases and selections and inclusions, exclusions built in, and the move to digital changes that, but in different ways, sometimes negative, sometimes positive. So what are your thoughts on that?
Yeah, I think you're exactly right. And actually, GP services is a really great example of things that had operated in a certain way for decades and didn't change. And then the digital sort of change has happened and accelerated in response to COVID in particular. And what we're finding is there is a real mixed public view and perception about the benefits or downsides of that. And actually, what we're finding is rather than trying to tell people of how to access these services, it goes back to having to design these services in a way that promotes inclusion rather than creates exclusion. And we've talked to some disability groups, for instance, where they've said when it's to do, if they physically would have struggled to access a GP service, having a digital front door has actually provided some equality for them, and they can access the service in the same way as someone who's physically able to go and stand outside a GP practice at 8 a.m. to get an appointment. What we're also finding is, we need to do more work to support GP practices to change how their practice operates and support. It's not a case of just dumping a tool in place and saying we're now gone to video consultation. We need to change how staff work, make sure staff have got the right training and support. It's much about the people, process and culture of adopting these innovations as it is transforming just how to use the technology in its own right. So a lot of really, really interesting work here. And yes, for younger people, there is we've got some insight and evidence that that's a kind of preferential approach. But actually, if you talk to young people in the most disadvantaged communities, a lot of them still would struggle to access the services. So it's it's how do we design services that are accessible by all is very, very challenging, you know, and paying particular attention to our disadvantaged communities who are more likely to suffer exclusion, more likely to suffer poor health outcomes, and how do we design services that they can access? And you know, if they can access it, probably everybody else would be able to as well. So it's a really interesting dynamic. Do you design for the many, or do you design for the people who would struggle to access it first and foremost? So yeah, we're lots to come on this. I keep saying if we solve this problem, we'll probably win the Nobel Peace Prize, because I think they're grappling with this up and down the country. But yeah, lots to come, I think, on that.
Thanks, Laura. Yeah, I mean, it's always good to set ambitions quite high, obviously. So Nobel Peace Prize, that'd be great. I'm just going to let Jackie come in before we move on to Phil's talk. Jackie.
Thank you, Niels. And yeah, a great presentation, Laura. And I think you hit the nail on the head. This is about being transformational, not transactional. If we just take and move across, we'll fail. But we'll build in all the same existing inequalities that we've already got. So it is very much transformational work. And just to give you a bigger picture view, the Equality Human Rights Commission have just launched their inquiry into inequalities in artificial intelligence for exactly the same reasons. It's if you just take the design that's designed with bias in, then you will get bias built into systems which we then rely on and are very hard to undo. So very important that we really rethink through the design, do our equality impact assessments, and design this new way of delivering fit for purpose by learning from the mistakes of the past. So absolutely with you on that, and great work. Very happy to continue to support you.
Great, thanks, Jackie. So let's move on to our final talk of today before we go to the panel discussion. In the meantime, we've been joined by Phil Swan, who leads the digital portfolio for the Greater Manchester Combined Authority. Hi, Phil, many thanks for joining, and the floor is yours.
Thanks, Niels. Can you hear me okay?
Yes, we can.
Great. I'm going to share a few slides if that's possible. We're going to give this a go and just see if it works. And I'll put that in. Is that visible in full screen mode?
Yes, it is. Yeah.
Okay, well, great. I'm just going to crack on then. I can't see everyone, but I think if you just let me know if there's any problems, that'd be great. So my name is Phil Swan. I'm lead on a digital portfolio for Greater Manchester Combined Authority. I'm director for digital here. And I'm just going to talk for a very short while about some of the work we're doing from a digital inclusion perspective. It picks up on a number of things that have already been discussed, and in particular some of the points that Laura was making just before this. But if I could, I'll start with just a bit of scene setting, just for in the context of the Independent Inequalities Review, which was undertaken end of last year, start of this year, and the Independent Inequalities Commission produced this report on to help us better understand how we can address inequalities at scale across Greater Manchester, and it set out quite a compelling vision for good lives for all in Greater Manchester, and critically, what this was about is how we mainstream activity across the city region to design better services and use all the levers at our power to address inequalities. This work created a really interesting framework, which you may have touched on already today, which looked at both demographic inequalities, geographic inequalities, and some of the entrenched and intersecting inequalities, particularly relating to socioeconomic inequalities. And the point here in particular is that this is a very complicated situation, and the intersections between the different factors which address inequalities are a multitude. And in that context, it's really important to think about digital as not only a specific area of inequality, but the intersections between digital and lots of other parts, other drivers of inequalities across the city region. Now, the report highlighted connectivity in this context. You can see it in one of the blue verticals in the central section towards the right-hand side. But actually, it's not just about connectivity from a digital perspective. As we know, it's about skills, it's about confidence, it's about motivation, it's about security. and all these other aspects which are critical, and affordability obviously plays into that really critically. The pandemic's massively exacerbated this, and I think if I can just move on, well, one of the things I want to touch on in that context is introduce you to a guy called Bernard. Bernard is the chap on the left who lives in Salford, and in his own words, not long ago, had decided he didn't want to live anymore. And that was partially driven, or heavily driven, by being so socially isolated through the pandemic. And if you get the chance, and I'm sure we can share the link after this, do listen to his experience and his life story. He got involved through word of mouth, but got involved with a program called Tech and Tea, organised in Salford and supported by a charity called Henshaws as well. And he was massively digitally excluded, but also socially excluded in a broader context, partly because of the pandemic, as I say. And it's turned his life around in terms of his ability to reconnect, to an extent now that he helps other digitally excluded older people get online. It's a really powerful story as to why this is so critical to address. And I just pulled in this headline, which many of you will be familiar with, about the impact of loneliness being worse than smoking or obesity. But yeah, we're perhaps not giving it quite the same priority certainly at a national level. Nationally, we haven't had a digital inclusion strategy in England and Wales since 2014, although there is one in Scotland. So it is a real challenge, and it does need addressing. And part of the reason it needs addressing is in Greater Manchester, and I know Laura shared these figures as well. We have about 1.2 million people who are digitally excluded in some way. Of that, about 450,000 are classified actually as non-users, out of a population of just under 3 million in the city region. And those figures are huge. And digital exclusion impacts lots of people in different demographics in different ways. So, for example, you could be a young person who's amazing at TikTok, but actually has never really used email and wouldn't know how to use email in a work context or any of the kind of word tools, or able to bank online and so on. At the other end of the scale, with older people, it may be more about confidence, it may be about skills, it might be, it may also be about affordability. So there's different factors that impact digital exclusion across the city region, but the scale of it is huge, and it's something that has really been brought into the limelight, as it were, through the pandemic. The Mayor has also given his backing to this, and in his manifesto earlier this year, he made a particular focus, a particular priority of getting under 25s, over 75s, and disabled people online. And a lot of our work over the last few months, over the last 6-7 months, has been ramping up around these priority groups and building on work that we started in October last year, when we announced an ambition as part of the GM Digital Blueprint for 100% digital inclusion across Greater Manchester. So how are we doing this, and what's the overarching approach? And really, there's 5 broad areas that play into this, and I'm going to just touch on some of these in the remaining time available. They are in themselves quite in depth, and we could spend quite a long time talking about each of these. But let me just skip through some of the points, and then we can maybe pick them back up in the panel. One of them is actually knowing who is digitally excluded and where they're digitally excluded. And we've been doing a really interesting piece of work led by the research team in the Combined Authority, working with colleagues across the city region and building on a model that was actually developed in Salford, building a thing called the Digital Exclusion Risk Index, which we've built for both Greater Manchester, but because the data sets are national data sets, we actually built it for the whole country as well, and launched it in November. And it enables us to overlay different factors around connectivity, deprivation, age, and so on, to give us a sense at a lower level super output area where the risk of digital exclusion is highest across the city region. It gives us an ability to think about our resources and where we focus more effectively. The other thing we've been doing a lot of is actually understanding, well, how much provision is there. Now, the scale of this is huge, and there's no magic bullet, and there's no single large funding pot to enable us to help address digital exclusion across the city region. So what we're trying to do is tie together and pull together a whole range of different activities across the city region, and make it easier for people to access and know what support is available where and so on. So we're actually just in the middle of a piece of work at the moment, mapping the support across the city region as a whole and within each locality. And the intention is to turn this into an easily searchable source for information, almost in this concept of having a single front door for support for digital inclusion across the city region. In terms of some of the other areas we've been looking, Technology Fund was something we launched at the start of the pandemic, and so far this has pushed out about 3,500 bits of kit and connectivity for young people, particularly focused on young people and complementing some of the national programs. And devices is almost devices is a success story, but is only part of the challenge. Data and connectivity and affordability of particular issues, and at a national level, those are conversations that we're having with government and with Openreach and others in terms of some of the kind of core costs and the models around that, and the options that are available to try and address this at scale across the city region. We're still looking for organisations to donate kit and technology though, and we are looking at building that into a GM data bank, which is something we're working quite closely with Good Things Foundation and others on. One of the opportunities that I think we ought to put more focus into, and increasingly are, is using social value, which is increasingly high profile at a national level, and at Greater Manchester level we have some of the most progressive work in the whole country. A particular example here is a recent procurement, a full fibre procurement, which is a £30 million dark fibre build out across the city region, which was won by a Virgin Media business. And through that, they committed considerable social value to help address digital exclusion across the city region. And these are just some of the stats relating to this at the moment. They've supported the tech fund, they're providing volunteering hours. We have 21 community centres that have got free connectivity for 5 years, and so on and so forth. And we're looking to build on this and do more with this. And they've actually seconded at their own costs a member of staff into our team full-time to work on digital inclusion, which has enormously helped this area progress. And then just in terms of some other key areas of work, and I know we've already talked about healthcare and the primary care review, and the whole healthcare digital transformation approach led by Health Innovation Manchester is really compelling in terms of its ability to bed into the design of services, digital inclusion. Another example is the DWP, the Department of Work and Pensions, work with TalkTalk on support for job seekers. So job seekers can apply to have kit and connectivity for 6 months paid for to enable them to get online, because pretty much now, unless you're online, it's very hard to look for a job. We've just completed a discovery activity with about 50 participants from our Digital Inclusion Task Force, which is a broad group of about 150 organisations, 150 people from various organisations rather, and really interesting findings from that, and some great ideas about how we work forward at a national level. And just touching on the last couple within these, because I've mentioned the national level engagement already. We're working with 5 different housing providers and 5 telco companies, given that 20% of our population is in social housing, and often the people who are most digitally excluded, to look at what we could do to work with them to reduce cost, to increase affordability, to improve access, and so on. And that work is initiating early in the new year, having done all the kind of hard work behind the scenes to get that off the ground. Another good example is the Care Leavers Initiative, and again, we're looking to support 4,000 young people a year who leave care, and a consortium coming together around that, again, working quite closely with the telco sector. So in some ways, I think that those are both really good examples about how we move forward as a whole to address some of the challenges around digital inclusion. It does require everyone to own this. It's one of these areas that no one necessarily has it in their gift to solve. And actually it does need both a bottom-up, hyper-local response, which is absolutely critical, particularly around skills and motivation, connected with city region-wide activities, service design activities, and so on. It does need that cross-cutting approach, and people to come together from all levels to work on how we address this. But it is a huge challenge, undoubtedly, and we're only going to address digital inclusion across Greater Manchester if we continue to collectively work together on this and people embed it in the day-to-day of what they're doing and the services they're designing and operating. So I'll leave that there. Thank you very much for the opportunity to talk today.
Great, many thanks, Phil. Exciting to see what's going on in the region. Lots of initiatives and really good work, I think. I think we're going to move straight on to our panel discussion, if that's okay with you. I can see there's a question in the chat from Nikki, which might be primarily focused at you, Phil. So, Nikki, would you like to unmute perhaps and ask your question?
Yeah, thank you. Yeah, so my point was just around whether we, and I think making digital more accessible is absolutely fantastic, but it should never be positioned as the kind of the be all and end all. Some people will always prefer to speak to individuals on the phone. And I know this from running a national charity where the helpline is still pivotal, although digital access channels, support channels are still important. So I think that's the first point to say. And what I do, I mean, sort of in personal life, I think we've all had the experience of trying to communicate with a bot that doesn't get what you're trying to say to it and how frustrating that can be. So, and I think sometimes, bots can be introduced too early or without sort of there being any backup plan, and so that can lead to poorer customer service. So it's just kind of putting that on the agenda as to how do we ensure that that doesn't happen. And then the last point, which was actually the first point I made in the comment, was just around would it be possible to look at all commissioned providers being specifically mandated to have a policy in place that shows what they do for those individuals who don't have access to digital means or don't want to have access as well. It's also that some people don't want to go digital for all sorts of reasons. I mean, certainly us as running an anxiety charity, people are very worried about data and security and all of that side of things. So, you know, that can be a reason for choosing to digitally exclude themselves. Thank you.
Phil, would you be happy to respond to that?
Absolutely. No, I think that point around bots is spot on. I won't mention any particular organisations, but I've been having a nightmare with getting through a non-public sector organisation's bot-based process over the weekend. Yeah, I think we need to be careful about how we use some of these technologies and be very mindful. There is a real push, and we see it in terms of the high street impact. You know, in terms of the reduction in face-to-face capability, and we're seeing it in the reduction of online humans, as it were, in terms of call center capability, as the shift towards bots increases. If you have something that's non-standard and complicated, then it's undoubtedly a significant challenge, and we need to be very careful with that, because there is a sort of bit of a Gartner hype cycle around automation and bots at the minute. But we need to be very careful that we are making sure we're using those with digital exclusion very much in mind, and ensuring accessibility is absolutely predominant in our thinking there.
Hi, Charles, you got your hand up.
Yeah, I just wanted to add to that and say, yes, the importance for older people of having offline services and access to those, and the fact that quite often, even if there's a commitment to offline services, they can be end up being sidelined, poorly staffed, poorly maintained, and then they become inaccessible anyway. So it's not just about providing that; it's about providing a quality service alongside the technology. So yeah, just wanted to add that.
Thanks, Charlotte. Yeah, I guess it's a bit of a paradox to some extent, right? Because I think most of the technologies, in principle, offer an increase in efficiency, which can be beneficial to provide better access. And I think that's something that we see in primary care, for instance, where access has been a problem for quite a few years, actually. But through digital technologies, there's an opportunity to improve that. But then it could also actually make it worse if those very technologies are not accessible to everyone or not usable by everyone. Any thoughts from the other panel members. And thanks everyone for turning on your camera. Laura, do you want to come in?
Yeah, sure. I mean, just on the question or the sort of suggestion about factoring inclusion requirements into service specifications, contracts, requirements, you know, I think is a good challenge. Certainly, you know, from an NHS perspective, all services and all providers are required to do an equality impact assessment. But I think it's fair to say that can sometimes feel like a tick box exercise, and we need to move that away from being such. And that's where I'm kind of coming from, of how we build inclusion into our design and delivery, supported by the right service operating procedures, supporting staff with training, because digital first services are very, very different to how staff have traditionally operated. And it does take a whole holistic view of, you know, staff and people and patients and access points, inequalities, the processes that services have in place to optimize digital technologies. There's no point in putting a digital first booking system in place if operationally the service still manages it in the same way. So there's a lot of work to do to kind of look at how things actually operate in practice and service processes and procedures. And then the culture. So something on the primary care work in particular we're picking up is the public that we've spoken to and the patient groups we've spoken to, actually they understand some of the opportunities of digital, and they also see a lot of the barriers. But I think there is an issue in public trust on digital services, especially in healthcare, because some patients feel like it was done quickly in response to COVID, rather than seeing that it was always a plan and an intent from the NHS. So we're kind of finding there needs to be a lot of public trust and education building to support patients to want to choose a digital service with the confidence that they will still get the same level of service, be it digital or face-to-face. You know, we want to design and deliver digital first services that are channel agnostic, and you get the same level of service depending on how you access it, at your choice, at your convenience, etc. So I think if you look at other digitally transformed industries like banking and retail, etc., they're decades ahead of the health service in this, but it feels like now we're at the start of that journey. So, you know, in 10 years' time, I could imagine that there would be some sort of formal commissioned requirements of how digital health and care services need to operate. And, you know, it may take some legislation to enable that to happen. Who knows? We'll have to wait and see.
Niels, if I could I just make a comment around that, which I think Laura points out something really important, which is there are an awful lot of people who would much rather deal with their GP online, and you made that point earlier as well, Niels, and actually doing so will hopefully free up resource from the system that enables more targeted approaches and more effective approaches for those who do need, who want a more face-to-face or telephone interaction. And actually, there are absolutely opportunities to do that across the system. You know, the fact that it is so, at the moment, or at least up to the pandemic, have been so face-to-face orientated was massively inconvenient for a huge number of people, undoubtedly. And you see that in some of the evidence which you've alluded to. So that it does feel like, and there is a long way to go, as Laura says, but it does feel like it's a massive opportunity, both for the NHS, but also for patients. And something I just dropped in the chat earlier, we had a blind individual talking at one of our events not long ago about his experiences, and he was saying, you know, the NHS still writes to people. He says, I'm blind. I have to go and find someone to read this to me. I want this, you know, this email has been around forever, you know, and we're still writing to people. He says it's massively inconvenient. So actually being non-digital in that context is excluding him. So it actually goes, you know, it does need looking at in the round for some of this. And the last point that I think is an opportunity as well is that for a lot of people, the NHS app has been a new experience through the pandemic. But because we're using it for travel and for COVID passes and so many other things now, there's a question as to whether or not that is becoming a new standard, and whether or not actually there's an opportunity in that context to address aspects of digital inclusion, helping people take more ownership of their health records. It won't be for everyone, absolutely, and that's really important. But in the context of different channels for different services that suit people and more effective for both people and the NHS, capabilities like the NHS app, which we've seen leap forwards in the last 18 months, need to be really thought about.
Thanks, Phil. So just for everyone on the call, if you have a question for the panel, then please enter it into the chat or raise your hand, and I will ask you to come in and unmute. There was a question in the chat from Anthony. So Anthony, would you like to come in?
Yes, thanks, Niels. My questions are starting to really flow now. Brilliant session, everyone. Thanks ever so much. Really appreciate it. Just from a personal experience this weekend, going to see my mum, and it's only when you actually get into the detail of spending hours with somebody that you really start to understand what the frictions are and what the problems are. So there's many examples, but a quick one. My mum can afford to invest in technology and things, but she chooses not to. And one of those examples is she uses TalkTalk email. And just going on and getting email set up for her this weekend, the amount of like nonsense adverts meant that you couldn't even come across an email. And it's just the friction and the levels of complexity because of that simple little thing, like she's gone for free option because she doesn't want to spend money, means she's bombarded with nonsense. She's never going to get any messages. And there's other things, there's loads and loads of examples, but my point is we only get to really know this stuff when we spend proper time with people. And otherwise it's just really easy to assume that this is the problem. But I think, and again, I've done lots of right care long-term scenarios where we do case studies and we sort of say, right, in the optimal scenario, this is what happens. In the suboptimal story, this is what happens. And you really get to the depths of what's going on in people's lives. It always pays back when you get it right first time. So if you, like the example of the deaf person, if we as a community and a social services, etc., spend those hours early days understanding each individual, getting the systems right for them, it will massively pay back. But we have to invest those hours for that individual, is my view. Just running numbers and case studies on these things in the past, if you get it right first time, it absolutely pays back. But sorry, lots in there for the panel.
Thanks, Anthony. Any comments from the panel? Any responses to what Anthony mentioned there? Phil?
I think brilliant point, Anthony. I mean, it's why the hyperlocal approach is so key. Like organisations like Tech and Tea in Salford, which I've talked about, and there's with a whole variety of these small organisations that are helping communities and individuals and communities help each other, because it is really difficult. How do you know which email supplier to go with to set things up, and then you're getting into the difficult world quite quickly of is this a genuine email or is someone trying to get my bank details, which is a huge concern, and I'm sure many of us share that on this call. One of the questions is, I think, in this space is, to how much does this start to overlap in sort of in healthcare terms with social prescribing, and actually is there an opportunity in that context? And I'm sure some areas already are. Apologies for not having the answer to this. I'm sure other people on the call do. But actually, should we be prescribing for individual support linked into local communities that helps them get online in a safe and secure and reliable way, and help people that they can phone up and ask questions to without feeling they're looking stupid or uncomfortable in that context, and that's something that the NHS is in a almost unique position to do, but it is a big challenge, and it's something that would need to be done at scale. But in an area like Greater Manchester, you'd really hope that would be something we could champion and do first.
I think that's a great idea, Phil, and you're very right about the phishing emails. That's a great example, I think. I mean, it's a terrible problem if you think about it, and it's also getting to a level where, you know, even I sometimes feel unsure about the stuff that I receive. So how is that for others who are less digital literate? So yeah, really good example. And I think you're absolutely right. We need those communities to help people. Andy first and then Laura.
Thanks, Niels. I think one of the stark realities is where we've seen meltdown of our current systems, where people have tried to get access to doctors or surgeries or direct care, and they're faced with making maybe 100 to 200 calls to place an appointment. That system doesn't work. You know, that system isn't digital. That should be something we can, you know, to book an appointment, it should be digitally easy for everybody to do, and yet seems to be far further away now than before. And I think, you know, I said it at the beginning of this, we've got some unique examples within Greater Manchester. I would love to see that patched into best practices from other countries, because we've got so much to offer, so much to give and learn from each other, that if we just do this within the M60 corridor, we're missing a trick. And I think, you know, the examples of the work across a combined authority, the examples of work across Health Innovation Manchester are really fantastic examples. And I'd like to be able to showcase those internationally as well as nationally, and pick up where we can perhaps enhance those and improve those. And then lastly, I'll leave you with this. We talk about digital by design, but we still refer to digital health. Okay, in the banking sector, you don't have digital banking, you have banking. You know, we don't have digital Amazon. I mean, I use the Amazon example. We don't have digital Amazon, it's Amazon. Okay, so why we're still prattling on 10 years, 20 years on, still referring to it as digital health? It should just be health. And it's digital from the good, you know, from the get-go. So I think sometimes language helps. We're still languishing in that, oh, is it telemedicine? Is it e-health? Is it whatever? We need to think a bit more clearly, I think, about how we talk about health.
Thanks, Andy. I have a lot to say about that, but I'm going to hold back now because I'm not on the panel. So Laura, did you want to come in or not?
Yeah, just briefly on kind of what Andy and Phil have both said, I guess. So I think it's an interesting one of why do we call it digital health and not just health? For me at the moment, I think that's part of our evolution of where the health and care system is. And from a public's perspective, and I guess the media do create this separation, but I'm not sure the NHS is quite fully digitized enough that they themselves even see that it is a seamless service. And I think there are those kind of, be it artificial barriers or not, and it's an interesting one to unpick for another session, I think. And, you know, at what point would the health and care, would the NHS be so digitally transformed it would just feel like the NHS and you wouldn't notice the difference? Feels like that's a long way off in terms of where other industries have got to. And I think Amazon's a great example of, most people see Amazon as a consumer goods organization, but actually it's a digital organization, isn't it? And every interaction with them is digital first and nobody bats an eyelid, but it's great because you get everything you need the next day. Not sure the health services is quite able to offer that level of customer efficiency and intimacy, but, you know, really, really interesting. And something else we're kind of looking at, picking up on what Phil said about the ridiculousness of paper and letters being sent across the NHS, is we're looking at how we develop a public access to record and information. And again, that will throw up all sorts of inclusion matters that we need to consider. But how do we give people access to their own information to support them to be more empowered to look after their own health and well-being, etc.? So loads to do on that. And I think one of the earlier points from someone on the during the presentations was about people realising that in order to access digital NHS services, they need to have access to internet, data, etc. at home, which will cost them money, but they don't have to pay to go and access a clinic. So I think that's a really interesting point. And again, I don't think we've quite got our heads around that either. So it feels like we're at the start of a really big era of transformation in the NHS and health and care system. And, you know, in 10 years' time, we might be sat here saying, talking about more artificial intelligence rather than just getting the basics right. I think that's what we're trying to do at the moment, is just get those basic things in place from a digital health and care system.
Thanks, Laura. I'm going to let Louise come in, and then I'll go to a question from John in the chat about legislation, and then I'm going to bring the discussion to a close. First, Louise.
So 2 side points. First is trying to bring back this point that sometimes technology can mask wider problems. So I think when we were talking a lot about primary care and how it relies on old models, actually the structure of primary care has changed vastly. So it's gone from quite small local practices that were quite easy to access to, you know, quite big partnerships now that are more difficult, more distant. So actually there's been a lot of change within primary care. And although we could provide more digital technologies and improve access that we've seen throughout the pandemic, that's not going to improve the infrastructure and capacity within primary care. We know there's a huge workforce crisis within primary care. So, you know, although we can increase these things, we're not going to increase capacity unless we're also funding primary care properly and supporting the people who work within primary care. And I just think it's just something to be mindful for, that we can try and change these services, but unless that infrastructure and resource around it is there, it's going to fail. We're not going to improve access because there's nobody there to pick up the digital inquiries because, you know, the staff have gone. The other second side point is that we recently conducted some citizens' juries around health data sharing, that I can post a link to. And just to point out, you know, we talked today about how people have got trust in like Amazon and all these other kind of companies. I think health data is different because the public see it's quite uncontained. It's not just NHS data, it's the role of government, it's private organisations, it's primary care, it's secondary care, it's the care system, it's other government organisations. How do we create trust when, you know, health data is at the moment seen as quite uncontained and not very transparent? So that's just something else to bear in mind.
Thanks, Louise. Yeah, two really good points, I think, and you're absolutely right there. John, would you like to come in regarding your point on legislation?
Thank you very much, Niels. That's a really excellent presentation, set of presentations this morning. I think as technology develops, eventually you get to a point where, where you have to make some fairly major choices about what you do, and it's often at that point that you legislate, or somebody legislates. Somebody is brave enough to say, the institutional position is maybe stable enough, the technology has settled down, if you like, and obviously the evidence is particularly strong for the need for it, and health inequalities really are glaring, and it's a big thing, a big uphill task. So we've got to think maybe that at some point or other, somebody somewhere, maybe the process will happen, and that we'll get some kind of crystallization. And the risk is that, of course, when you do legislate and when you do get some kind of fixing, you narrow choices down, and then you then stop maybe innovation happening. But I think that we've got to maybe think that at some point, maybe the next 5 years, there will be somebody who says, right, we've got to legislate in this area and really enforce standards and access. Thank you.
Yes, thanks, John. And I think that's a really important point, going back to what we were saying previously about banking and retail. So yes, they've made the turn decades ago now almost, but they never had to worry about access, right? And they didn't. I think Amazon never worried about that. They didn't have to. That's a huge difference. And I think John's right there, that we have to make sure that everyone's rights to access, for instance, are protected properly. And you probably have to use legislation for that. So any thoughts from the panel on that point? Phil, yeah.
Yeah, Niels, if I could. I think the banking example is a really interesting one, and because the banks are both incentivized to get people online because the cost per transaction is lower, but also if someone is subject to online fraud, then they carry the can to a large extent. So it's in their interest as well. Plus, also, given that the difference with Amazon is that Amazon aren't really bothered if you're digitally excluded and not part of their mainstream market, whereas banks actually do have to provide across the whole sector, and I do have an accountability within that context. So it's probably a better analogy. And a lot of the work that they've done setting up digital legals, Barclays digital legals, Lloyds who invested heavily in that, TSB, they all work in communities to try and help people get online. Some of the big programs across Greater Manchester have been backed by the banks to help those most digitally excluded to get online. So they are putting their money where their mouths are because it's in their interest of their business model. So I think that is useful to consider. The legislative one is also really interesting. And one of the problems that we have, though, is that if you look at, for example, digital policy across government, it's actually quite well split between three areas: NHS, Cabinet Office, and Department of Culture, Media and Sport. So if I get slightly off my hobby horse for a second and just make a very brief point, if you look at something like identity and how we manage knowing who is who in the UK, and it's 2021, almost 2022, we still don't in the UK have a reliable online means of knowing who is who. And the policy for that still sits across three different parts of government. And until that's resolved, actually, we're not really going to address this. And this has been, talking with a senior group across government recently, it's probably the biggest issue in terms of digitisation of public services in the UK, and it has been for probably 15 years. That is, so we have some really fundamental things. Coming back to your point around legislation, actually, we're not even clear about who should be drawing that legislation together at the moment across the whole system. So there's some really intractable issues that we don't see getting resolved rapidly at a national level. In the Greater Manchester level, I think the opportunity for us is to say, well, okay, what is it that we can do that could make a difference? Because with the powers we have, devolved powers we have here, and the size of the population and the willingness to collaborate and work together, is there something we could do at the Greater Manchester level that helps address this whilst the national position gets resolved and works as a test bed for a national, a test bed that could be then rolled out nationally. So I don't think there's a lack of willingness to try and do this, but we have some really fundamental challenges that exist in this space at the moment, to pick up Anthony's point.
Thanks, Phil. Yeah, and I think that's exactly what we should do in Greater Manchester. We should try to be ahead of the troops and set an example that can be followed in the rest of the country. We're in a position to do that, I think, and let's try to make it happen. I'm going to draw the discussion to a close. Thanks everyone so much for participating today. I think it's a really fascinating topic. We could probably go on for hours. I'm sure it's a topic that will come back at a future ecosystem meeting. Perhaps we can pick it up in 12 months' time, see where we stand at that point in time. For now, I would just like to thank all our speakers very much. Fantastic to have you here today at the meeting. Thanks so much for your contributions. I'd like to thank everyone who's on the call for joining today, and like to point out that the next ecosystem meeting is going to be held on the 10th of February. So please mark your diaries. We're going to focus on new partnerships and innovations that have emerged during the pandemic, especially partnerships that are cross-sectoral, so for instance, between academia and industry, or the NHS or the public sector. We've seen obviously in the pandemic that there's been lots of those new partnerships which have brought innovations, and we felt it's a good time now to reflect on those and see what we have, what the pandemic has brought us in that respect. So that's going to happen on the 10th of February, and then further ecosystems will happen probably in April and June next year. And you will obviously receive an invitation for that. For this event, we will make sure that the slides and the recording will be available on our website. So thanks again for joining, and I hope to see you in February. Thanks.